Thank you a lot for the nice deliberation on the topic. So, should we move? Yeah.
Thank you.
So, may I invite Dr. John, Mathew, and in the second topic on GI malignancies, multimodality therapy for locally advanced gastric cancer, evidence-based clinical approach, and will be delivered by Dr. John Mathew Manipadam. And he is from the same place from Dr. H. Ramesh, that is Cochin, Lakeshore Hospital. And so please go ahead and have some 3 minutes time for discussion.
Good morning. I thank the organizers for this opportunity. My topic for today is multimodality therapy for locally advanced gastric cancer, an evidence-based clinical approach. I shall begin with saying what we do in our department. We essentially follow a multidisciplinary approach and a tumor board and a team which is in constant communication with each other so that there is a flexibility to change the modality of therapy quickly if according to the needs of the patient. In surgery, we essentially follow staging laparoscopy followed by a radical D2 gastrectomy and additional organ resection of, say, the pancreas, spleen, or colon only when there is a direct infiltration by tumor. This will be followed by adjuvant therapy and preoperative neoadjuvant chemotherapy we generally reserve for locally advanced lesions where we feel in the preoperative imaging evaluation an R0 resection is unlikely. So let me come to now what the evidence tells us. I shall go in these 4 categories: surgery, neoadjuvant therapy, adjuvant therapy, and finally tissue agnostic therapy. In surgery, we all know most cancer centers in the treatment guidelines are now advocating D2 gastrectomy with the goal of removing more than 15 lymph nodes. And the cornerstone of the evidence comes from the Dutch trial, which had a 15-year follow-up where they had 380 patients in the D1 arm versus the D2 arm, 331 patients. And they found that there were fewer gastric cancer-related deaths with D2 and fewer locoregional recurrences with D2. And though the overall survival was not significantly different, in the subgroup analysis of those without a pancreatic splenectomy, there was indeed a significant 15-year survival, better survival with D2. Coming to para-aortic lymph node dissection, is there a role for prophylactic para-aortic lymph node dissection? This was addressed in this Japan Clinical Oncology Group 9501 study, where they included locally advanced disease without gross metastasis to para-aortic lymph nodes, and 135 patients in each arm, D2 versus D2 plus prophylactic para-aortic lymph node dissection. They found that there was no survival benefit, and it only increased the surgical complications. What for those patients who have positive para-aortic lymph nodes? This was the subject of this Chinese study, wherein they selected patients with 1 to 3 likely positive para-aortic lymph nodes, and they compared this versus D2 dissection. They did a propensity match retrospective analysis, and they found that 40.6% of the positive para-aortic lymph nodes were indeed positive on histology, and the 5-year survival rate was significantly higher. The recurrence rate was lower, and the complications, of course, as expected, was more with diarrhea and lymphoria. So in well-trained centers and well-experienced hands, maybe we could add in a patient with a positive, limited positive para-aortic lymph nodes, we could add positive para-aortic lymph node dissection in addition to the D2 radical gastrectomy. Now let me come to the neoadjuvant chemotherapy. There is an increasing trend in literature of starting with neoadjuvant chemotherapy in those with a high possibility of developing distant metastasis. And they include patients with bulky T3, T4 tumors, any patient with visible nodes on preoperative imaging, any patient with a linitis plastic appearance. And as we can see in this study from the National Cancer Database, there is an increasing trend from 2006 to 2014 of the use of preoperative chemotherapy. However, there is no single study which is showing an overall survival benefit compared to the surgery plus adjuvant approach. So why then are they barking on it? Because the logic is that the patients who are at high risk of developing metastasis, they may be spared the morbidity of a gastrectomy if metastasis develop later after neoadjuvant chemotherapy. This, according to me, is a rather Darwinian approach of natural selection where you're selecting the patients with good tumor biology and excluding those with bad tumor biology. I feel somehow we may be losing out on the opportunity to salvage those patients who have locally advanced lesions, who are not metastatic yet, and who have bad tumor biology. So I was not alone in, there are others in literature who have the same feeling. This study from the treatment from China, they analyzed the treatment switch in poor responders with locally advanced gastric cancer. They found that in the MAGIC and FLOT4 trials, the rate of poor responders, according to the tumor regression grade, was an alarming 43 and 38%. So they concluded in the discussion that timely surgery is important and that treatment using chemotherapy should be undertaken with greater caution, and D2 surgery followed by chemotherapy protocols may provide a better outcome opportunity. Coming to the cornerstone trials of neoadjuvant chemotherapy, the MAGIC trial, we all know, compared 250 in this chemotherapy plus surgery arm versus surgery alone. And as we can expect, there was significantly higher progression-free survival in the chemotherapy group because there was no adjuvant treatment given in the surgery group and the patients do not have a strict D2 lymphadenectomy. Coming to the Prodigy trial from Korea, which also analyzed neoadjuvant, docetaxel, oxaliplatin S1, followed by surgery, followed by adjuvant S1 versus surgery and adjuvant S1. They had 530 patients in an intention to treat analysis, and we find that 46 were excluded because 24 in the neoadjuvant arm withdrew consent, and 13 patients were ineligible for chemotherapy because of inadequate organ function. And we find in the surgery arm, the 100 patients, the 100% underwent surgery, though in the chemotherapy arm, 16 further dropped out. And they were adverse, and this was because of adverse events, disease progression, death, and such. And the median time to surgery was also delayed. However, they showed a significant improvement in progression-free survival at 3 years, but not overall survival. So we can see here in the consort diagram of that study, there were 40 patients who underwent a non-curative surgery. And the reasons for it is given in this table, that they had opened and closed 18 patients out of the 240, out of this 40. They have mentioned earlier in the study that staging laparoscopy was used whenever necessary. So maybe it was metastatic disease, maybe it was disease with organ infiltration, and they did not go for a multivisceral resection. And did these patients undergo neoadjuvant chemotherapy to downsize the tumor? What happened to them? All these are not analyzed in this study, and I feel that this is indeed a drawback of this study. And which is why in the NCCN guidelines also, they give emphasis to staging laparoscopy even before starting chemotherapy or surgery. And the jury is not out yet on neoadjuvant chemotherapy because for locoregional disease, they mention surgery or perioperative chemotherapy. Let me add to the confusion by quoting the study from a Japan Clinical Oncology Group, where there were 158 patients in each arm with locally advanced gastric cancer, neoadjuvant chemotherapy with S1 plus cisplatin followed by surgery compared to surgery plus adjuvant with S1. And they, in their results, there was no progression-free or overall survival benefit. So they concluded that D2 surgery followed by adjuvant chemotherapy still remains the standard treatment. Coming to some neoadjuvant regimen, as we all know, the FLOT4 AIO trial showed a significant survival benefit of FLOT over this traditional ECF regimen. However, in our Asian populations, it is generally believed that there is more myelotoxicity with FLOT. There are some newer trials coming up, the Japanese trials assessing the efficacy of combining taxanes with S1, and Ramses study, which combines ramucirumab with FLOT, which is ramucirumab is a VEGF inhibitor. And in the preliminary interim results, 180 patients, they showed a higher margin-free resection with adding ramucirumab. So I will not dwell much on neoadjuvant chemoradiotherapy because it's already discussed by Florian, and it is definitely showing survival benefit with cardiac cancers and esophageal, though this tends to be grouped along with esophageal cancers. And the POET and the New Ages trials showed some benefit. The adjuvant therapy, we all know that any disease beyond T2, we need to give adjuvant therapy. And for patients who have an adequate lymphadenectomy, we give them chemotherapy. Who do not undergo a D2 dissection and who has had a R1 or R2 resection, we give chemoradiation. There were many trials and meta-analysis which proved the same. I shall just highlight a few. The CAPOX trial, the classic trial which used CAPOX showed a survival benefit. FOLFOX showed a survival benefit. The AXGC trial, where S1 was given as adjuvant therapy, that also showed a survival benefit. The JACRO GC07 trial showed a survival benefit with docetaxel plus S1, and this was significantly better. Coming to adjuvant chemoradiotherapy, the ARTIST trial, did not show survival benefit when compared to adjuvant chemotherapy alone. The ARTIST-2 trial followed the same. The CRITICS trial also did not show survival benefit with adjuvant chemoradiotherapy when compared to adjuvant chemotherapy. However, this retrospective comparison with the D1, D2 trial, where they had 91 patients who underwent surgery plus chemoradiotherapy, they found that indeed it reduces the local recurrence when the patient has underwent a D1 lymphadenectomy or has underwent an R1 resection. So let me come to the final section of tissue agnostic therapy. This is the buzzword in oncology right now, wherein the origin of the cancer doesn't matter, whether it's the stomach or the colon or the pancreas, but indeed the molecular signature matters. And this is diagnosed, molecular signatures found by immunohistochemistry or in situ hybridization or targeted PCR, followed by next generation sequencing if it is required of the entire tumoral or germline genome. And in the NCCN guidelines for CA stomach, a universal testing for microsatellite instability by PCR or NGS is recommended in all newly diagnosed patients now. This next generation sequences assesses the high tumor mutational burden, and in patients who have a limited tissue available for testing or who are unable to undergo a traditional biopsy, this helps by doing a comprehensive genomic profiling. Some of the molecules, trastuzumab, pertuzumab, this inhibits the homo and heterodimerization of HER2, and this has already shown benefit in advanced gastric cancer, which overexpress HER2. Now in the perioperative neoadjuvant setting, also it has shown benefit. The Petrarca trial, where trastuzumab plus pertuzumab has been combined with neoadjuvant FLOT, has shown a significantly better disease-free and overall survival and increased complete pathologic response. And now with cisplatin also it has been combined and is the subject for the innovation trial. Coming to immunotherapy, there are patients with a deficient mismatch repair mechanism in gastric cancers, and these tumors are hypomutated and more immunogenic, and there are immune checkpoints that exist to dampen this immune response by which the tumor grows. So one such is the PD-1 ligand expressed on tumor, which binds to the PD-1 on the activated T cell. And the inhibition of this results in improved tumor killing, which is the basis for the immunotherapy with pembrolizumab and such molecules. So it has been found that 3 to 7% of esophagogastric adenocarcinomas are actually MSI high, and the keynote trials have shown benefit with pembrolizumab. Now this is an individual patient data meta-analysis of 4 classic randomized trials, and they found that 7.8% of these patients are MSI high. And in these MSI high patients, though, they found that these patients had a better overall survival compared to MSI low, they did not benefit from perioperative standard chemotherapy. So this is the subject for this neoadjuvant trial, NEO-NIPIGA, wherein they had 32 patients, wherein they gave neoadjuvant immunotherapy rather than neoadjuvant chemotherapy. Nivolumab, ipilimumab surgery, followed by adjuvant nivolumab, and it's a phase 2 trial currently. And they found that of the 29 who underwent surgery, all had R0 resection, 60% achieved a pathologic complete response. And the 3 who did not have surgery had actually a complete endoscopic response with tumor-free biopsies and a normal CT scan too. So let us hope that these molecules give us a better cure and help us in our armamentarium for curing these patients with locally advanced gastric cancer. Thank you.
Thank you very much, Dr. Manipadam, for this summary. Just a remark, when the Western studies, done in gastric cancer, they don't have a neoadjuvant arm. It's a perioperative concept. So they begin with chemotherapy, continue with surgery, and then give additional chemotherapy. Yeah. Secondly, you have presented a mixture of esophageal and gastric cancer trials. It is true that not all trials include a specific cohort of only gastric cancer, but because I'm just marking this out because your title was in locally advanced gastric cancer. For you have spoken about the MAGIC trial, the FLOT trial, and there are 2 other trials, the ACCORD trial and the AORTC trial from Germany itself for the management of locally advanced gastric cancer. So now to sum up with your own words, maybe in 2 lines, what is the evidence for locally advanced gastric cancer, excluding junction and esophageal cancers.
Yeah, as you said, the most of the studies have included both, so it's difficult to make a conclusion, as Florian also said. So, but I feel the neoadjuvant chemotherapy is still not for all cancers which are considered locally advanced. Maybe it is for patients who we feel R0 resection is unlikely to be possible with surgery.
This is true, but like Florian also pointed out that in this, I think it was a meta-analysis from the National Registry USA, where the R0 resection rate was quite low, or R1 resection rate was quite high in gastric cancer group. We do not accept in that paper the data, but we are willing to accept the poor R0 resection rate in MAGIC trial and also the ACCORD trial, which we take as basis for perioperative therapy.
I could understand your question.
No, the question is that these trials are very poor actually.
Yeah.
The MAGIC trial and the ACCORD trial.
Yes.
You have R1 resection rate of 2 digits in those both trials.
Yes.
Yeah, and applying the current standard, like Florian has pointed out, today we cannot accept these R1 resection rates.
Yeah.
Florian.
Thank you for this good overview. I have 2 questions. One is, you pointed out that the R0 resection rate was higher, for example, in this Japanese study, but this was not translated into a higher overall survival. And the second is, in almost all of the studies, we see a higher, of course, higher tumor regression compared to the upfront surgery. And this is also not translated in a better overall survival. What do you think? What is the reason for that? This is counterintuitive, I think. We have a higher R0 resection rate and, of course, a higher tumor regression, but this is not seen in the US in the end.
Yeah, as you said in that Korean trial, I fully agree with you, but that's why I also raised this point that in neoadjuvant chemotherapy, why there is no overall survival benefit, but only a progression-free survival. So maybe it is because as I said, in the surgery arm, they included patients who had metastatic disease. So the patients who they opened and closed, so these patients actually had metastatic disease, and so they came in the intention to treat analysis, and so the survival came down. Maybe it is that. So we really don't know. So what I conclude is that we need better trials with more focused approach in future.
Yeah.
So,
Florian, what I believe there are multifactorial factors affecting both tumor biology as well as the patient or host response. So actually receiving R0 doesn't reflect many times in the overall survival.
But I think when we compare Asian and Western trials, it is very important to differentiate. Like Florian, when you take the D2 versus DT trial from Japan, this was a purely surgical trial. None of the patients had perioperative therapy or even adjuvant therapy, only therapy, chemotherapy when a relapse was detected. And in that study, the R0 resection rate is almost 98%. And the median overall survival is, or not, after 60 months, they didn't reach the median overall survival. Whereas in all the perioperative trials from Europe, we see even in the interventional arm, also the patients who are in the MAGIC trial, in ACCORD trial, and even in the Schumacher trial, AORTC trial, I mean, you have a median overall survival of around about 3 years maximum, yeah? And we can learn from Asian countries, and when the lymphadenectomy trial in Netherlands and UK were conducted, the centers were taught how to perform gastric surgery, gastric cancer surgery from Japanese and South Korean surgeons. Either they were visited by those surgeons or they were provided detailed videos how to perform the D2 dissection, for example. And if you take the median overall survival in both trials, although the difference between D1 and D2 was not significant, but in both groups, the median overall survival was far over 4 years, which is almost double to the MAGIC trial and the ACCORD trial. Yeah? And even with the flood trial, you reach not more than 3 years median overall survival. And the flood trials don't have a surgical arm, just to point out. They just compare different chemotherapy regimes. Please, go ahead.
Hi, I'm Dr. Ramakrishnan from Cancer Institute, Chennai. Thank you for a very good overview of the multidisciplinary management. And I'm happy that you pointed out that neoadjuvant therapy is not always the go-to solution for advanced gastric cancers. See, the problem is India doesn't fit in either in relation to the Western data or to the Far Eastern data. We come somewhere in between. We see a lot more of locally advanced gastric cancers presenting with gastric outlet obstruction. We see a lot more of signet ring cell cancers, which probably are not so common in either the Far Eastern countries or Western countries. So I don't think we should blindly ape the results of the trials conducted in either of these centers. We need to find a via media between these two. We have published a propensity score matched analysis comparing perioperative versus adjuvant, because there is hardly any trials that head-to-head compare these two arms, because all the trials, the comparator arm has only been surgery alone. And we have shown that there is no survival difference between perioperative chemotherapy or adjuvant chemotherapy. So I think the choice is more individualized based on the patient. A patient who comes with florid gastric outlet obstruction is unlikely to tolerate neoadjuvant chemotherapy.
Thank you very much.
Yeah.
We are just running out of time. Dr. Ramesh, just a short remark.
Point out that the quality of the D2 dissection has never been included as a factor in any of these trials, and that probably explains all the
That's
confounding
what I said.
stuff.
In the Western trials, it is
So
not.
I think it's a passionate plea to do
Yeah.
a proper D2 gastrectomy. Even after neoadjuvant therapy, the number of lymph nodes that's available is well in excess of 20, and in the naive patient, it's well in excess of 45. And if you don't have so many lymph nodes, it means you haven't done a good enough D2.
Or the pathologist has not done a good job.